during the Malaysian Fellowship Humanitarian trips last year in August, I went with a team to Bihar in India, and we worked in the villages and we had a great time. The students learned a lot, and it was the first time that, I guess for those first timers who went on the trip, it was the first time they actually experienced what it really is like to be working as a doctor. So there were even a first-year medical student, there was, I think, third or fourth-year medical students, and some, those who had just graduated. And they all had the same sort of experience, of seeing and feeling and experiencing what it's like to be a doctor when you've got a patient in front of you, presenting with a symptom, and then you've got to work out what is wrong with the patient. So you've got to work out how to take history, what to examine for, how to arrive at a diagnosis. Now, the reason we decided to have this talk is because I got a bit worried at some of the more senior students, because what I noticed is that they had a lot of knowledge, right? They were like walking textbooks. And some of them had more knowledge about a lot of medical conditions than I did myself. But when it came to actually making a simple diagnosis of a condition that was so common, a condition that every day, GPs in Malaysia or in emergency departments are dealing with, they couldn't work it out. But they can give me a lecture about Wagner's granulomatosis, or acute lymphocytic leukemia, or non-Hodgkin's lymphoma. But in terms of diagnosing a simple chest infection, right, they were having trouble. And so we had some tutorial sessions. Is anyone from my team last year who's here today? Hands up? Only one. And came out the back. Everyone else got frightened away, isn't it? But yeah, and I guess from then we decided to organize something like this. I guess to try to help you to start thinking like a doctor, how to come to a diagnosis, and how to diagnose common things which occur very commonly. So, this slide, diagnosis, I guess you all know what a diagnosis is, and for the sake of the junior students, a diagnosis is basically the cause of a patient's illness. Now, look, I don't want you to take any notes, right? So put all your hands down, because we've got printouts of all my slides, which we'll be giving out to you at the end of this lecture. Right? I want you guys to just sit back, relax, listen, and start thinking, because I'm going to be asking you questions in the second half of this. Right? So it'll be more of you guys thinking and talking than I am. And hopefully you can teach me something too. So diagnosis, cause of the patient's illness, we subdivide it into acute versus chronic. Right? Acute is something that is a new diagnosis or a new condition that has just very recently arisen in the patient. A chronic condition is where it's something that has been occurring for at least a few months. And for a lot of people, it might have been going on for years. Can someone give me a hand with this? In terms, we just need to make this bigger. Yeah, that's good. Okay. Now, with chronic conditions, you can have an acute exacerbation of that chronic condition on top of the underlying chronic illness, right? And what is a classic example of that? Sorry, louder? Bronchitis. So, acute on chronic bronchitis. Very good. Another one? Pancreatitis, yeah. Asthma, yes, exactly. Okay. Acute complication associated with the underlying chronic illness. So, like you've got an underlying chronic illness affecting, say, a particular organ, but then you get a known complication of that illness occurring somewhere else in that patient's body. What's an example of that? Gastric ulcer? Yes. but what are the complication of that? Perforation, causing hemorrhage, hematemesis, anemia, right? Very good. Acute intercurrent illness. So you've got a particular illness, and then you get another illness that's occurring on top of that. So like, for example, a patient with chronic renal failure who gets a flu as well. That would be an acute intercurrent illness. Okay. Now, this starts to become a bit interesting. The way we doctors think and come to a diagnosis, right? Basically, it can be quite mysterious, and sometimes it can occur by magic. So, I could look at a patient and in less than 60 seconds make a diagnosis by just observing the patient, right? And it might look like I've done that by magic, but it's by what we call intuitive reasoning, which is recognizing a combination of patterns of findings that will suggest a diagnosis. That means you have to have a lot of knowledge, and you have to have a lot of experience to be able to recognize, patterns of symptoms or signs to arrive at a diagnosis very quickly. And that's how a lot of doctors actually make a diagnosis these days. So the medical officers and above will be making diagnoses in that way. And a lot of house officers will actually start doing that, usually after at least 6 months of experience. And I guess for a lot of medical students, the difficulty is getting from where you are now into that stage. So we have what is called, let me move down a bit, transparent reasoning, which is, I guess, it's not bad. Oh, okay. Maybe I need someone to do this with me then. Okay, you want to stay in? So we have transparent reasoning, which is, I suppose, just a transparent way of logically thinking through a series of steps to get to the diagnosis. So it's like a very simple analogy of this is like when I say to you, like Jen, what's 10 plus 10? Exactly. Are you sure? Yeah. And the reason that you know that is because you know that 10 plus 10 is 20, right? But if you are a 5-year-old boy and I ask you what is 10 plus 10, you'll be probably, marking on a piece of paper, 10 strokes, and then 10 strokes, counting all of them and getting 20. That's how young children learn basic maths. And that's more a transparent way of learning it because it's a logical, stepwise approach to learning what 10 plus 10 is. But through experience, Jen, through, I don't know how old you are now, but after 20 years, you've worked out that 10 plus 10 is 20. Right? And it's almost by magic, isn't it? And that's the difference between intuitive reasoning and transparent reasoning. And I suppose what I want you guys to learn is how to sort of work through transparent reasoning so that you can work through the steps to arrive at a reasonable diagnosis that is accurate and eliminate all the, other differential diagnoses that may not be accurate. And with experience and time, you eventually just bypass that step and go on to intuitive thinking and reasoning. All right. Next slide. Okay. So, for example, we select a diagnostic lead, which is like a symptom or a sign or a test result. And in this example, we're choosing acute abdominal tenderness in the right lower quadrant of the right iliac fossa. Okay, very simple one, surgical problem. Second step, choose a differential diagnosis that's linked to that symptom. So as you can see, we've chosen appendicitis. Okay, right iliac fossa pain, most commonly caused by appendicitis. All right, the third step is look for more information. Look for a finding that occurs often in the chosen diagnosis, but less often in other differentials. So a sign of appendicitis or another piece of information would be localized scarring. Okay. Um, and then on the next step, you start thinking, right, appendicitis will thus occur more frequently in patients with right iliac fossa pain and localized scarring, right? But if a new finding comes along, which could be a better lead with fewer differentials, like for example, a CT scan result, then you could use the CT scan result instead. Say for example, you then, you think maybe this patient has appendicitis because of a symptom and a sign, and then for some silly reason, someone organized an abdominal CT, and the abdominal CT shows something, then that can start changing the way you think, and you might start changing your differential to something else. I guess if a female would present with right iliac fossa pain, then you've got to exclude gynecological problems hemorrhage. So that's where maybe a CT scan can help, right? And what would be the causes of right iliac fossa pain in a female besides appendicitis? Ectopic pregnancy, yeah. What else? Ovarian torsion, yeah. Any more? Ovarian cyst, yeah, exactly. Hemorrhage into an ovarian cyst. Okay, but if it's a male, then of course you eliminate all that. So it's important to know what sex is and what sex-related conditions are. Okay. And then the single diagnosis will become, I guess, the final diagnosis if it explains all the patient's findings. Okay, very, very simple example there. All right, now let's skip to the last slide. Can we do that? Okay, this is a case example. Meishi, would you like to tackle this one? Okay. So, 2-year-old boy brought to you by mother. The boy is distressed and crying, indicates pain in the left ear, had a fever which began the night before. Mother gave him paracetamol in the morning to no effect. What is your plan? What would you advise the mother about? This is, I know you're not in final year, but this was actually our exam question for our final year medical students at the end of last year in Sydney. Yeah, so it's a sort of final year exam question, but I'm not asking the final year students because I don't want to worry them too much. So, Rishi, what is your plan and what would you advise the mother about? Okay, don't worry if you're wrong because there's no right or wrong in this one. Do you want me to ask someone else? Okay, Eric? Yeah?
Can.
Sorry? Bacterial infection? Yeah? Where? In the ear? Yeah? Where in the ear? Someone over here, I heard something. Big voice? Otitis media? Excellent. Very good. But the question is, what is your plan? It's not, I mean, it includes diagnosis too, yes. So you're thinking and you've worked out that those symptoms could be due to acute otitis media. Very good. What else could it be? Sorry? Parotitis? Yeah, excellent. What else? Foreign object in the ear? Yes, can. Children are always putting things in the ears, and if you get stuck, eventually you can get infection, and you can get fever and ear pain. Yes, what else? Respiratory infection, where? In the respiratory tract. Which is where the ear is, yeah? Where else in the upper respiratory tract? Sorry? Nasopharynx. So you're talking about sinus, nasal sinuses, throat infection? Yes, can. What else? What is one very important diagnosis that no one has mentioned yet, which we need to exclude to save this child's life?
Scarlet fever.
Scarlet fever? That's one, yeah. But more important than that? Sorry? Yeah, okay. We've exhausted all the ear ones now. Yeah? What kind of neurological problem? Like what? A tumor in the brain. That's pressing onto the trigeminal nerve. It's possible. That is entirely possible, and that is not wrong. Meningitis, that's the one I'm looking for. Why meningitis? Because there's fever, there is pain, and the child is unwell. Right? It's probably not as likely as acute otitis media, because you've got localized pain to the ear. But then in a 2-year-old child, how do you know, where the localized pain is? A 2-year-old child doesn't usually tell you, oh, I got pain in my left ear. The 2-year-old child is just crying, and it says indicates pain in the left ear. Usually they're just scratching or pulling at the left ear. But the child could actually have neck stiffness or headache that's diffuse, and you don't know about it because the child can't actually tell you. It's probably not a very fair question to ask you guys, but it's a pediatric question. It was actually a question in our final year medical student exams, right? And the highest mark that I actually gave out was to a Malay girl from Port Dickson, right? And this is what she said to me. First of all, I think the most likely diagnosis is acute otitis media, but we need to actually rule out other differentials such as meningitis, mastoiditis, pharyngitis, pneumonia. So my plan of management is to examine the patient, have a look in the ear. I would expect to look, if it's otitis media, I would expect to see a red bulging eardrum, and there might be actually pain on actually putting the oroscope into the ear. I would like to check for lymphadenopathy. I would like to check for neck stiffness, photophobia. I would like to check for capillary return to see if the child has got septic shock from meningitis. I would like to look for a rash to exclude meningococcal septicemia. I'd like to listen to the chest for signs of pneumonia such as tachypnea, bronchial breath sounds, crackles, wheezes, all the rest of it. And then after that, I would then like to do some, if I think that this child hasn't got any of the other things but just acute otitis media, then I'll be talking about what kind of investigations or treatment with the parents. Now, that we don't need to do any treatment, investigations, because it's quite simple. Most cases of acute otitis media are caused by a virus. So antibiotics are usually not indicated in the first 24 hours unless there are complications. So if there are no other complications, I will actually advise the mother to continue giving paracetamol and then come back in 24 hours later so that we can review the patient and then work out what to do. If the patient is getting worse, then they should contact me before that and bring the patient back for me to review. That's what our final year medical students are like in the exam situation. And someone like that, I didn't have to ask any questions. I just sat back, let her talk. And I just went on and on and on, and it was all just music to my ears because she's actually telling me what I want to hear. That she has actually got medical knowledge and she knows how to apply her medical knowledge. She knows how to recognize common conditions. This is a very, very common condition. And she also knows how to think laterally. Like, what else could it be? What are the dangerous things that we need to rule out and not forget about, like meningitis? And she knows a bit about the latest research about medical treatment because I guess up until recently, a lot of people were treating acute otitis media with antibiotics, but the latest research does show that there is not much difference in the outcome between using antibiotics and no antibiotics, but just with simple analgesics. Yeah, so she was able to think like how a doctor should think. And for someone like that, I'd be most happy for her to come and work in my team in the hospital because I know that she knows what she's doing. I know that she's safe, I can trust her, I can rely on her, and I can depend on her. And I know that she will not be ringing me at 3 o'clock in the morning saying that I've got a patient with fever, 38 degrees, crying, pain, and I don't know what it is, but what do you think it is, Dr. Ram? Right? And she can also communicate all that information to me instead of saying, oh, it's pain in the ear, in the respiratory tract, and I'm asking, well, which part of the respiratory tract? Respiratory tract is from the nose and down in your lungs. So where? We need to be precise, we need to be accurate, we need to be able to communicate with people. Otherwise, the person on the other line of the phone will be thinking, what kind of idiot are you? Why are you working here when you don't know these simple things? Now, I don't mean to make you all feel like idiots, because you're not. You're all top students. You all did really well in your, is it SPM in Malaysia in order to come over here to do medicine. So you're all very bright. You all have all the knowledge, right? You all can think. But what you need to do is to be able to think in a logical sequence. Start adding up the symptoms. Does this symptom plus this sign equals what? Right? And think. Common things occur commonly. Right? So, like your example about a brain tumor pressing on a trigeminal nerve. It's correct. That does happen. But how common is that? Yeah, that's right. So it's not really wrong, but it doesn't help the situation because it's so rare. Right? And I know you guys know about all the rare things and all that, which I don't even know about because I am not concerned about rare things that I never see in my life. I'm more concerned about things that occur commonly that we see every day. And we need to work out how to fix them. Alright, next. Where am I up to? Okay. So, moving backwards a bit, to make a diagnosis, history, examination, investigation. Okay? Now, from the presenting symptom, like that case example, what was it? Pulling the left ear and pain. So, pain in the left ear and fever, so 2 symptoms. Right? Automatically, I want you to think, what are the 3 most common causes that can cause those 2 symptoms in a 2-year-old child? Okay, and some of you got it right already. Acute otitis media, and then you're thinking about, upper respiratory tract. That's correct, right? But also, I start to think a little bit further from that particular area, and try to get at least 3 things. If you get a longer list, it's even better. Right, but at the top of your list should be the one you think is most likely the cause of that. All right, and then after that, you got to go through the history. So your history is not a matter of going through a ritual, asking about this and that and all that kind of stuff. Your history is designed to find out whether what you are thinking is right or not. So you're basically like a detective, right? You're looking for clues, you're trying to solve this mystery of what's causing problems with this patient. So ask about, I guess those symptoms about how long the pain's been there, what the child is like in terms of the activity levels, whether the child has got a runny nose, which will, point towards the upper respiratory tract. Ask about, I guess, other questions. But mainly ask about the symptoms so that you can actually elaborate and build a story around that symptom. Okay. You also need to then look at other symptoms that are associated with that. So you need to ask about nausea, about vomiting, about photophobia, about anorexia, things like that, to start ruling out some of the differentials on your list. And then at the end of the history taking, you should already then review your list of differentials again. You know, is my list correct or do I need to change it? You know, does the evidence that I got just from the history support what my provisional diagnosis is, or is it one of my differences instead? Okay, so be thinking about what you're talking about. And then that will then help you work out how to do your examination. Right? Examination is not examining a person from head to toe. It does involve that, but if you don't have a lot of time, then you just want to focus in on that part of the body that will give you the money, you know, where the problems are. So like for this child, you know, the pain is in the ear. You want to go and look at the ear as one of the first things that you do, right? You don't want to have to, I mean, you don't want to do a neurological examination or an abdominal examination. I mean, you can later on, but go for the one where you think you're going to find the answers to, right? And then by the end of the examination, you review your list of differentials and you work out, is my provisional diagnosis correct or do I need to change it? And then after that, if you need to do investigations, then what you're thinking of now will influence what investigations you ask for. And you know, every investigation that you order should have a reason. You know, you don't do things just because it's out of routine or a baseline thing. You need to have a reason for every test that you order. So like for this child, right, I've had MOs who will ring me and say, we've done a full blood count, electrolytes, liver function, calcium, magnesium, phosphate, and blood cultures. And I'll be going, why did you order all that? And then they say, well, full blood count, we need to check the white cell count because that will be elevated if there's a significant infection, right? We need to check the CRP, inflammatory markers, which will be elevated if there is a significant bacterial infection. What about electrolytes? Oh, it's just a matter of routine. We had some extra blood, so we did that. Or liver function. I'm thinking, like, do you think the child's got hepatitis? But having said that, in children, that's what we normally do. Because it's very difficult to draw blood out of a young child. So if you're going to take blood out of a young child, we try to make the most of it and try to order a whole lot of things. So that in case we need to think of ordering another test, at least it's already been done. We don't need to hurt the child again to do it again. Okay, but in adult medicine, you shouldn't be thinking like that. It's should be quite different. And then once so your investigations are there to help you confirm your provisional diagnosis or to change your provisional diagnosis so that you then arrive at what the final diagnosis is. Got it? Simple, isn't it? Good. All right. We're going for time. Not bad. What's the next one? Okay, yeah, let's go on to systems. Now, systems. This is a couple of extra things that I do when I'm not sure what's wrong with a patient. So look at systems. So like coming to that case example, right? We're thinking respiratory system, aren't we? Because we're thinking upper respiratory tract. But you know, there's someone who thought about neurology system, right? You can even think of some of the other systems, cardiovascular, I don't know. But this is something like a bit of a structure that you can go through. Because if you really don't know what you're dealing with, then start thinking about these systems. You know, does it belong to cardiovascular? Can I think, you know, is there any cardiovascular conditions that could cause these symptoms? No? All right, let's go to the next one, respiratory, you know. And then gastrointestinal. Is there anything there that can cause these symptoms? So it's a way of double checking that you haven't missed something. Okay, next slide. Pathology, I'm talking about the pathological processes here. So within the systems, you got different types of pathology happening, right? So like within the respiratory system, you can have infection, all kinds of infections. You can have tumors or cancer, you can have trauma, degenerative conditions, autoimmune, vascular, metabolic. Again, another structure that I sort of use to help myself, work out that list of differentials within a system. Okay? So this is simple stuff. You guys will be doing this in the next half of the session. Okay, next one. All right. So let's have another example. Cough. Okay, and this is something that I did with the guys on our humanitarian trip last year. We went through some of the common symptoms and we talked about what could be the most common causes of the symptoms. So cough, a very common one, right? You can cough can be divided into acute and chronic. So for acute causes, those would probably be the common ones, like upper respiratory tract infection, right? The cause of an upper respiratory tract infection is most likely viral, 6 out of 7 times. And it's just that 1 out of 7 times that it could be bacterial. Scarlet fever, for example, right? So most of the time, you don't need to treat with antibiotics. Post-nasal drip due to rhinitis, sinusitis, allergic viral bacterial, right? Lower respiratory tract infection like pneumonia, COPD. Is that what you guys call it over here? From smoking too much? Yeah. Okay. And then other things which are less common, like pulmonary ambulances, aspiration, heart failure. Okay. Chronic causes, I suppose chronic bronchitis or COPD in the smokers. Again, the post-nasal drip can cause a chronic cough. Gastroesophageal reflux disease, asthma, drugs such as ACE inhibitors, very common. A tumor progressing in the upper airways, becoming less common now, and then bronchiectasis. So, can you see that the progression of starting with the common things and then you gradually get less and less common, right? It doesn't help you if you do it the other way around, right? And so, like when you're working in a hospital and the consultant asks you what's the cause of this, and you come up with some whiz-bang rare condition, it doesn't actually make you look smart. It actually makes you look the opposite of that. Next. So history. All right, let's, can we go back to the previous slide? Okay, so someone presents with a cough, right? Help me out here. What questions do you want to ask for, what questions do you want to ask for in the history?
Smoking.
How long? Yeah, what else? Color of flag, yeah, so is there a productive cough or not? Okay, if there's a productive cough, what does that make you think of? Pharyngitis, yeah, what else?
Pneumonia.
Pneumonia, yeah, what else? Bronchiectasis, yeah, what else? Very common in Malaysia. TB, yeah. Asthma, usually not a productive cough, unless you've got a superimposed bacterial infection on top of that. But usually it's a dry cough, and it's non-productive. Okay, what other conditions would you be thinking of that could be associated with the cough? We had that up on the slide before. So we've gone down the respiratory tract system already. So what other system? It's there. Your friend is helping you. So, yeah. So the GIT system. So heartburn, hoarseness, chronic nocturnal or early morning cough. Those will be symptoms of reflux disease. Asthma, like exposure to dust or allergens. And then if you've got a smoker, you've got a chronic cough and sputum, it's most likely COPD, but you also have to think about cancer. Okay? All right, don't go on the next one yet. So we move on to examination, right? What do you want to look for in the examination? Which system you want to look at? Respiratory system. Okay, and in the respiratory system, what do you want to be looking at? Which part of the respiratory system do you want to start off with? Some upper and some lower. Okay, fine. So the upper respiratory tract, so you're looking at throat, you're looking at the ears, looking at the nose, right? And then you move down to the lower respiratory tract, listen to the chest, look for all the chest respiratory signs. Okay. All right. Next. So, and then you're familiar with all those signs then. And then we move on to investigations. What kind of investigations will you order in someone with a cough? I'm hearing a lot of whistles. I need some loud voices. Chest X-ray to look for what? Yeah. Okay. TB, cancer, pneumonia, any kind of changes. What kind of changes do you see on a chest X-ray in someone with asthma? No changes? Are you sure? Hyperinflation, that's right. What are the signs of hyperinflation on a chest X-ray? Yeah? Lung field is dark. Is there a nicer way of explaining that? Radiolucent. Okay, lung fields are more radiolucent, so they're darker because they're hyperinflated. Posteriorly, yes, diaphragm below the ninth rib. Anteriorly, diaphragm below the sixth rib. Someone was saying six. Is that right? Well, it's a sixth rib. Right. Heart shadow might look a little bit narrow as well. Okay, besides chest X-ray, what else can you order? Someone with a cough. Sorry? Yeah, that's right. Send off the student for culture. Yeah, what else? Spirometry, so you're talking about lung function testing. Alright, and what conditions do you want to do spirometry in? Asthma and COPD. Good. Would you do that in pneumonia? Why? Because you don't need to. Okay? And because in pneumonia, the patient is acutely unwell, so will underperform on the lung function test anyway, so the results will not be accurate. So there's no need to do one. Unless there is a history of chronic asthma, and then you might or might not want to do one depending on the situation. Very good. Okay. And then if you suspect the patient could have gastroesophageal reflux disease, what kind of test would you want to order? pH testing. Exactly. The pH probe is the gold standard. But if you're in a hospital where you can't get access to a pH probe, then a barium. Swallow, meal, enema, what kind? A barium swallow? Yeah? Excellent. Okay. And I guess if you're in a major center, you can also look at doing a bronchoscopy. If you've done all those other investigations and you're still not quite sure what is going on, then the next thing would be to do a bronchoscopy. All right, next. That's it? Okay, that's it. What's the time? All right, we could have now how are you guys going? Do you want us to continue with the second half now, or do you want to have a 5-minute break? 5-minute break? Continue. Continue? Okay, let's continue. Have you got the next one?